Welcome to the deep dive.
Hey there.
You know how this works, right? You've got your notes, we've got them too.
The ones on Anterior Uveitis. Notes on inflammation of the eye.
Exactly that. And our job,
Yeah.
it's to pull out those, gold nuggets, make it really clear.
Yeah, crystallize it for revision. Today it's all about Anterior Uveitis, also known as Iritis.
Right. We're aiming for that high-yield overview.
Precisely. We'll cover the definition, the causes, the risk factors, what's actually happening in the eye.
Pathophysiology, yeah.
And differentials, who gets it, the clinical picture.
Investigations, management, super important prognosis, and those complications we want to avoid.
Okay, let's make these notes stick. So, first things first, definition. What's the absolute core concept?
Okay, so anterior uveitis, or iritis. At its simplest, it's inflammation of the iris.
The colored part.
Yep, the colored bit and the anterior chamber, that fluid-filled space at the front.
Right.
Crucially, as part of the uveal tract, the iris, ciliary body, choroid, that whole structure. And you often see it with a red eye, right? It can be one eye or both.
Exactly. It's a common cause of red eye. Can be unilateral or bilateral. And here's a key link to remember early on.
I bet it's the HLA-B27.
You got it. Strong association with HLA-B27 and the conditions linked to it. So that's a big clue.
Okay. And uveitis isn't just one thing, is it? There are types.
Correct. We classify it by location. We're focusing on anterior, the front. But there's also intermediate, posterior, and panuveitis, which is, well, everything.
Gotcha. Now, digging into anterior uveitis itself, the notes mention granulomatous and non-granulomatous. What's the deal there?
The key difference lies in the keratoc precipitates, KPs, those little deposits on the cornea.
KPs, right.
So non-granulomatous usually presents acutely, and the KPs are small. Think small KPs, acute onset.
Okay.
Granulomatous tends to be more chronic, and the KPs are larger. They sometimes call them mutton fat KPs.
Mutton fat KPs. That's vivid.
It is. And it's a good mental hook, because granulomatous uveitis is more likely linked to underlying systemic diseases. So see mutton fat KPs, think systemic.
Okay, that's a great tip. Mutton fat equals think systemic. What about duration? Acute versus chronic.
Yeah, another key classification. Acute comes on suddenly, resolves usually in weeks.
Abrupt onset.
Exactly. Chronic hangs around for more than 3 months. And unfortunately, that often means more persistent vision issues.
Right, makes sense. Something else in the notes. It said that even if you suspect an infection, the initial treatment is often similar. Why is that?
That's a really practical point. The #1 goal initially is just to get the inflammation under control. Fast.
Calm the fire first.
Precisely. Plus, identifying the exact bug in the eye isn't always easy or necessary right away. Getting good samples can be tricky.
Yeah, the notes mention that. Cultures might not even be helpful sometimes.
Right, especially if they've already used some antibiotic drops. So the strategy is treat the inflammation first, then investigate the cause if needed.
Okay, clear definition, classification sorted. Let's move on to the why. Etiology. What triggers this?
The causes often are, honestly, we don't find a specific cause. It's idiopathic.
Frustrating.
It can be, but generally it boils down to the immune system getting it wrong, an immune response gone awry.
So the body attacking itself, essentially.
In many cases, yes.
Okay.
Things like infections, known autoimmune diseases, or even just general systemic inflammation can set it off.
Like which conditions?
We see it a lot with things like Ankylosing spondylitis, reactive arthritis, those HLA-B27 ones again, but also Behçet's disease, sarcoidosis.
Okay.
The notes break down potential causes nicely. Autoimmune, infectious, trauma, iatrogenic meaning caused by treatment inherited, ischemic, and idiopathic, the unknown bucket.
And specific eye syndromes too, right?
Yes, certain ocular syndromes can cause uveitis, anterior or posterior.
So who's more likely to get this? What are the risk factors?
Well, probably the biggest one is having had it before.
History of uveitis. Makes sense.
Definitely. Then those systemic conditions we mentioned, ankylosing spondylitis, reactive arthritis, sarcoidosis, they significantly raise the risk.
And the HLA-B27 marker itself.
Absolutely. Being HLA-B27 positive is a major standalone risk factor. And don't forget, infections like herpes simplex or TB can also be triggers or risks.
Okay, so history and associated conditions are key flags.
Yeah.
Now, the pathophysiology, what's actually happening inside the eye, the mechanism.
Right, the how. Fundamentally, it's inflammatory cells invading the anterior chamber.
Immune cells going where they shouldn't.
Exactly. The immune system gets activated, releases cytokines, those signaling molecules, and boom, inflammation.
It's a cascade reaction.
It really is. Any intraocular inflammatory disease can trigger this uveitis response.
Yeah.
Trauma, infection, autoimmune reactions, they all lead back to these inflammatory cells and cytokines.
The notes mentioned molecular mimicry. That sounds interesting.
It is. It's a fascinating concept. Sometimes an infection triggers uveitis because a part of the bacteria or virus looks very similar molecularly to a protein in the eye.
So the immune system gets confused.
Precisely. It attacks the infection, but then it also attacks the similar-looking eye protein, like mistaken identity on a cellular level.
Wow. And different causes might have slightly different patterns, right? Like Fuchs or sarcoidosis.
Yeah, the underlying mechanisms can vary, leading to slightly different presentations or common associations, like with Fuchs heterochromic uveitis, sarcoidosis, or just straightforward idiopathic acute anterior uveitis.
Okay, that makes sense. So someone comes in, red eye, pain. What else could be going on? The differential diagnosis.
Critically important. You have to consider anything that causes a red eye or changes in vision. It's broad.
Especially for the non-granulomatous type.
Yes. Think about sacroiliitis, the seronegative arthropathies, ankylosing spondylitis, reactive arthritis, psoriasis, inflammatory bowel disease.
Okay.
Also early sarcoidosis or TB, Behçet's disease, juvenile idiopathic arthritis, early syphilis, leptospirosis, even drug reactions or simple trauma.
That's a hefty list. Systemic symptoms must be key clues then.
Absolutely crucial. Now, if you're suspecting granulomatous uveitis, the list shifts a bit.
Towards infections and more established systemic stuff.
Exactly. Think established sarcoidosis, toxoplasmosis, viruses like CMV, herpes simplex, herpes zoster, TB, syphilis.
Okay.
And in immunocompromised patients, like with AIDS, you consider opportunistic infections, CMV again, cryptococcosis, candidiasis.
And non-infectious posterior causes could mimic it too.
Yes, things like Behçet's again, VKH syndrome, lymphoma, even lens-induced uveitis. So granulomatous often signals a need to look deeper for systemic or infectious causes.
Really drives home the point about looking beyond the eye. So epidemiology, who gets this most often?
In the UK, anterior uveitis is definitely the most common form we see.
Okay. Any numbers?
Incidence is roughly 25 to 50 cases per 100,000 people per year. Average age of onset is around 30.
So primarily young to middle-aged adult.
Yeah, mostly 20 to 50 years old, but kids can get it too. About 5 to 10% of cases are under 16.
And does it vary geographically?
It can, yeah. And as we've said, susceptibility is really tied to those systemic conditions.
Are there specific age links to remember? Like for kids versus older adults?
Definitely. In children, think juvenile idiopathic arthritis, sometimes toxocariasis. Young adults, maybe Behçet's, the HLA-B27 conditions, Fuchs uveitis.
And older adults?
Could be things like VKH syndrome, herpes zoster, ophthalmicus, TB, and in some regions, leprosy.
What about gender? Any differences?
There are some tendencies. Males are more prone to uveitis, linked with ankylosing spondylitis, reactive arthritis, Behçet's.
Okay.
Females show a higher link with rheumatoid arthritis and juvenile rheumatoid arthritis. So yeah, age and gender provide useful context.
Good pointers. Okay, clinical features. How does the patient actually present? What do they tell you?
Usually it's a pretty acute onset. They'll complain of eye discomfort, maybe outright pain, often worse when they try to focus.
Pain with use.
Yes, and the pupil might look small, maybe irregular. Photophobia, that intense light sensitivity, is really common. Classic symptom.
And blurred vision, red eye.
Absolutely. Blurred vision, obviously a red eye, maybe excessive tearing. You might see a ciliary flush redness concentrated right around the edge of the cornea.
What about hypopedia?
That's possible. In more severe cases, you see that layer of white cells settling in the bottom of the anterior chamber. Visual acuity might be normal at first, but it can definitely drop.
How does the presentation differ between acute and chronic forms?
Good question. Acute is typically sudden, often just one eye to start. Pain, redness, photophobia are usually quite marked. Gets worse over hours to days, maybe a headache too.
Pretty dramatic.
Can be. Chronic is often more insidious. Recurrent episodes, but maybe less intense symptoms each time. Blurred vision is often the main complaint. Sometimes mild redness. Less pain or photophobia except during acute flare-ups.
So chronic can be a bit more sneaky.
Definitely. Think acute, angry. Chronic, creeping.
And how do intermediate and posterior uveitis symptoms compare? Just briefly.
Intermediate often gives you painless floaters, maybe decreased vision, but not much going on at the front of the eye. Posterior is also more about gradual vision loss, floaters, often bilateral, but again, usually without the classic anterior pain and redness.
Pathophysiology is a mix.
Yeah, PAM means all, so you get a bit of everything. And critically, remember some uveitis, especially with JIA in kids, can be totally asymptomatic initially, super sneaky.
Right, important point. So when you examine someone, what are you looking for specifically?
Okay, examination is key. Check visual acuity first, then a careful look at the external eye, pupil size, shape, reaction, cornea for KPs, lens for clarity.
And then into the anterior chamber.
Exactly. Looking for cells, inflammatory cells floating around, and flare, which is like protein leakage, making the fluid look hazy, and hypopyon, if it's there.
What about the iris itself?
Look for synechiae adhesions between the iris and lens. Also, iris atrophy or nodules. Then check the vitreous for cells, look at the retina, macula for inflammation, swelling, vasculitis, optic disc too for swelling or infiltration, and measure the intraocular pressure IOP. It can be low or sometimes high.
And a full physical if you suspect something systemic.
Definitely. If the history or eye findings suggest an underlying condition, you need to look further. Oh, and there are actually grading systems for the inflammation severity used in clinic and research.
Okay, so diagnosis is mostly clinical. When do investigations come in? Lab tests, imaging?
Primarily clinical, yes. History and exam are paramount. But imaging, like OCT, optical coherence tomography, is super useful for looking at the back of the eye, especially the macula.
And blood tests?
X-rays.
You'd consider those mainly for cases that look granulomatous or if it's recurrent or bilateral.
Yeah.
Trying to find that underlying cause.
So things like FBC, ESR, ACE levels. Yep. Maybe ANA, RPR for syphilis. Definitely HLA B27 testing if suspected. TB tests like MAN2 or Quantiphon Gold. Chest X-ray for sarcoidosis or TB urinalysis.
Infectious workups, too.
Sure, if infection is suspected, toxoplasma, Lyme, HIV, syphilis titers. And in very specific cases, maybe analyzing fluid from the eye itself if you suspect infection or malignancy. But you tailor it based on suspicion.
Right. Targeted investigation. Okay, management, we've diagnosed it. What's the plan?
Goals are simple. Reduce inflammation, relieve the symptoms, prevent complications, and save vision.
Sounds crucial. An urgent referral is key.
Absolutely non-negotiable. Suspected uveitis needs an ophthalmology review within 24 hours. It's an emergency.
Okay, so what's the typical first-line treatment?
Usually starts with 2 types of eye drops. First, cycloplegics, like atropine or cyclopentolate.
What do?
They dilate the pupil. This relieves the ciliary muscle spasm, which eases pain and, importantly, stops the iris sticking to the lens, prevents those posterior synechiae.
Okay, pain relief and prevention.
Yeah.
And the other drops?
Steroids. Topical steroid eye drops are the mainstay for reducing the inflammation itself.
Got it. Cycloplegics and steroids. Any caveats?
Huge ones. Never treat recurrent uveitis in primary care without specialist advice, and steroid drops must be initiated by ophthalmology. Cannot stress that enough.
Right, specialist territory. What if it's more severe or chronic?
Then treatment gets tailored. Sight-threatening posterior uveitis might need systemic drugs, oral steroids, maybe immunosuppressants.
And for chronic anterior uveitis?
We treat actively if vision drops, say, below 612, or if symptoms interfere with life. We continue cycloplegics as needed. Corticosteroids remain key, maybe still drops if it's just one eye and chronic, but potentially oral steroids or even injections around the eye if it's worse, especially if there's macular edema.
When do the heavier-hitting drugs come in? Immunosuppressants?
You consider those for severe cases or chronic ones not responding well enough to steroids, or if you need to reduce the steroid dose long-term.
Like what drugs?
Methotrexate, mycophenolate, TNF inhibitors are common. Others like cyclosporin, tacrolimus are options too.
And if it's infectious?
Then you add specific antimicrobials alongside the steroids and cycloplegics. You treat the bug and the inflammation.
Are there even more intensive treatments?
For really tough cases, yes. Laser, cryotherapy, even surgery like vitrectomy might be considered. And lots of research is ongoing into biologics, new delivery systems.
Anything specific to check before starting steroids?
Yes. Always check the intraocular pressure. And crucially, rule out herpes simplex keratitis. Steroids can make that much, much worse. Dendritic ulcer is an absolute contraindication to steroids alone.
Good point. And surgery is mostly for complications.
Generally, yes. For severe intractable inflammation, sometimes diagnosis or managing things like cataracts or glaucoma after the uveitis is under control. Vitrectomy might help in some younger patients with severe disease.
How do you monitor progress?
Regular eye exams are the main thing. Slit lamp examination. OCT is great for tracking macular edema, fluorescein angiography if you're worried about retinal blood vessels.
And specific screening for some groups.
Yeah, kids with JIA need regular screening because their uveitis can be asymptomatic. Specialists monitor treatment effectiveness, side effects, complications. GPs might help monitor systemic effects of long-term meds.
Okay, prognosis. What's the likely outcome?
It really varies. Depends on the cause and how quickly it's treated effectively. Many cases, especially acute ones treated promptly, resolve well in weeks to months with good vision.
But chronic cases need ongoing care.
Yes, recurrent or chronic uveitis often needs long-term monitoring and management. Some mild cases might even resolve on their own, but you can't rely on that.
Relapse is common, though.
Unfortunately, yes, especially in younger people. Frequency and duration vary a lot. Newer treatments are improving things for difficult cases, though. Prognosis for chronic granulomatous types really depends on controlling the underlying cause.
Finally, complications. What are we trying to avoid?
Chronic inflammation is the enemy here. It can lead to serious problems.
With what?
The big ones are glaucoma, high eye pressure cataracts, those posterior synechiae sticking the iris to the lens, and macular edema swelling at the back of the eye, affecting central vision.
And the ultimate complication is vision loss.
Exactly. That's the main worry. It can happen from any of those things. Cystoid macular edema, cataracts, high IOP, also from vitreous opacities, retinal detachment, abnormal blood vessel growth, neovascularization, macular ischemia, vascular occlusions, optic nerve damage. Lots of potential pathways to vision loss.
Those posterior synechiae sound particularly troublesome.
They are very common and can directly cause glaucoma by blocking fluid flow, and they make future cataract surgery much harder. So breaking them early with dilation is key.
So treat early, treat effectively to prevent all that.
That's the mantra.
Wow, okay. That was definitely a deep dive into anterior uveitis. We've covered a huge amount of the definition, causes, risks, pathophysiology, differentials, epidemiology, features, investigation, management, prognosis, and those crucial complications.
Yeah, it really highlights how important spotting it early and getting that urgent ophthalmology referral is.
Absolutely. And while hopefully this discussion, based on your notes, really helps cement things for your revision, medicine is always evolving. Keep learning.
Couldn't agree more. Continuous learning is key.
And for anyone listening who wants more MSRA revision materials, do check out passthemsra.com.
And freemsra.com as well. Both great resources.
Brilliant. Well, thanks for joining us on this deep dive. Remember, everyone, stay curious, keep learning. It makes all the difference.